And that's why breast cancer, for example, in a disease that is very sensitive to insulin, if you have hyperinsulinemia, you're just going to be feeding that growth of the breast cancer cells more than you're feeding the growth of the normal cell. So therefore, you're going to favor growth in that situation, and therefore diseases of hyperinsulinemia, that is obesity, type 2 diabetes, are well known to be associated with breast cancer.
Welcome to Target Cancer Podcast. My name is Dr. Sanjay Juneja. I'm a hematologist and medical oncologist, also known as the Onc Doc on social media. And on Target Cancer, we're basically talking about all the things that you want to know outside of regular, chemotherapy and immune therapy, even though we talk about that as well. And that's why I'm super excited, as somebody who did intermittent fasting, but I don't know if it was technically the right intermittent fasting. We have Dr. Jason Fung, who is a nephrologist and really just like a metabolic kind of expert where and when it comes to glucose regulation, intermittent fasting, fats, and kind of dispelling, are fats bad, are they not? People say you end up eating a lot of fat on a keto diet. Is that a good thing? So, Jason, if we may, I would love to get into those things, and thank you for being here.
Sure, great to be here. Thanks, Sanjay.
Yeah. So one of the things that a lot of people talk about with intermittent fasting, just to get right into it, is it the traditional intermittent fasting that's the only real intermittent fasting when you go kind of that 24 36 hours, or does it count if it's that 16 to 18 hour duration where you're not eating, or versus 2 to 3 days? Are they both intermittent fasting? I know they are in semantics, but are they for functionally the purpose of what someone's trying to achieve if it relates to decreasing your cancer risk and mobilizing weight loss?
They both can work. I mean, you don't have to do the longer fast if you don't want to. It's a very sort of complicated issue. It's not so simple as, oh, you can fast and reduce your risk of cancer. You can reduce it, but it's in relatively complex ways. That was sort of what I talked about in the Cancer Code a little bit more, because a lot of people thought it was just, you fast and then you're going to reduce your risk, but it turns out that it's a lot more complicated than that. And that's sort of one of the things that I sort of delved into in that book, was sort of how cancer develops, because what I thought was very interesting was that it actually went far, far, far beyond just simple metabolic disease, but incorporated a lot of things, and how our sort of ideas of how cancer develops, like what is cancer, how they've changed in the last 10, 12 years. I think that's been sort of a really fascinating journey. So fasting can affect one aspect of it, but doesn't affect all the aspects of it. Like there's other things. From metabolic standpoint, of course, the good thing about fasting is that it's not just about low carb, because there are certain nutrient sensors in the body that are also growth factors. So you have insulin, which is great for low carb, but for sort of AMPK as well as mTOR, both of them are also growth factors, as well as nutrient sensors, and fasting affects all of them. So it's an interesting discussion for sure. But yeah, any of those can work. I mean, you can do shorter fasts, you can do longer fasts, but it's sort of a combination of sort of hyperinsulinemia, which is a sort of become a very well-defined risk factor for a lot of diseases. So if you look at things like obesity, the risk of obesity, the risk of cancer and obesity wasn't really well appreciated until 2001, I think. We never talked about it in the 90s, and it wasn't until there was that large study in the New England Journal published in 2001 that showed that, hey, it's actually a big risk factor. Now you have 14 different cancers which are defined as obesity-associated cancers. So therefore, fasting, if it helps with that, presumably is also going to lower your risk. And these include some of the most important cancers like breast cancer, colorectal cancer, for example, pancreatic cancer.
And so the obesity, because people ask, like, why does it have to be correlated? And some, say it's the adipose or fat tissue itself that kind of has a little bit more of an inflammatory and less of an immune system conducive environment that can cause it. You said hyperinsulinemia. So is the fact that you need more insulin to regulate your glucose in your blood, month to month, year to year, is it that itself that seems to cause an increased risk in cancer? Or is it the fact that your insulin is higher because you have increasing glucose, and ultimately really it's just the fact that your glucose levels are just kind of persistently higher? Or is it the actual like fact that you need more insulin itself that's also, in addition to the fact that your circulating glucose levels are higher, also a risk factor for cancer? And how?
Yeah, I mean, we'd have to back up a little bit. Two things. Like, I mean, I think so. In terms of how insulin affects cancer risk, it's sort of a long answer, and it's a different question than what you're talking about, which is insulin resistance versus hyperinsulinemia, which is a good question too. Insulin resistance is a very nebulous term, right? Because the whole idea is that your blood glucose is high, and remember, this is what we've been taught, and it's all wrong. We're taught that, hey, something causes insulin resistance, and therefore the glucose in the blood can't get into the cell. Therefore, your body has to produce more insulin in order to shove that glucose into the cell. Okay, so that's so-called insulin resistance, and that's sort of the whole wrong way to look at it. It's not helpful. Because if you think about insulin resistance, then you get to the question, so you say, okay, what causes high glucose? Insulin resistance. Well, what causes the insulin resistance? And there you have no answers. It's like, well, so some people, for example, say, oh, it's due to dietary fat, or it's due to inflammation, or it's due to this, due to that. Well, after 50 years of knowing all about insulin resistance, we still don't have an answer for what is it. And the other thing is that if the solution is to give more insulin, well, that's what we've done for so many years, right? We said, well, you need more insulin to overcome that resistance, and that's going to make you better. So does it make you better? Absolutely not. Because if you think about a type 2 diabetic, you give them insulin. What happens? They gain weight, they gain fat, and what happens when you gain fat? Well, your diabetes gets worse. So you're giving insulin to a type 2 diabetic, they get fatter, their diabetes gets worse, you give them more insulin. That's the whole, you're just making things worse.
You're literally just throwing kerosene in the fire.
Exactly. So if you think...
That was the most polite way of just like saying how none of this makes sense. Like you were just very kindly saying exactly what a med student or resident would say, but the way you said it somehow is just like, that makes no sense, and that was wizardry. So yeah, please continue. So you're right.
Absolutely. So that's the
complete
problem. Yeah, and I go in depth in the diabetes code, but the whole idea that this is the primary problem is insulin resistance, and then you ask the question, what is causing insulin resistance? We're like, I don't know, after 50 years, we don't know. It's getting worse, like the epidemic's getting worse, but we don't know. So there's two ways to look at it. So you either have an underfill problem or an overflow problem, okay? So think about the cell, the liver cell. If you have something that's blocking the entry of glucose into that liver cell, what's going to happen is that you're going to get internal starvation of that liver cell, right? Because glucose can't go in.
Right.
So therefore, what would happen? Well, you should lose weight. People should be skinny. They should have very, very small livers, shrunken livers, like type 1 diabetes. So you give insulin and everything gets better. So absolutely, that's type 1 diabetes. That's nothing what type 2 diabetics look like. They have huge amounts of obesity, they have huge fatty livers, and their blood glucose is high. So why can't this glucose go into the cell? So there's two possibilities here, right? It's either an underfill situation, so you're not getting the glucose into the cell. If you're not getting the glucose into the cell, why would weight loss help in any way with type 2 diabetes, with insulin resistance? It shouldn't. Wow. It's going to make no difference at all. So the other way to look at it is maybe this is an overflow problem. So maybe what's happened is that your insulin levels have been high for a long time. You've been shoving all this glucose into the cell for so long that this cell is just full of glucose. Therefore, what you would predict from this overflow way of looking at insulin resistance is that you have too much glucose inside the cell. It's overflowing. Now you have a big fatty liver. Check. That's what you get in type 2 diabetes. With this big fatty liver, it's going to try and get rid of all this fat. So you're going to pump out all this fat and you're going to get abdominal obesity. Check. That's exactly what you get. The reason the glucose cannot go into the cell is because insulin has opened up the glucose receptor, but there's so much glucose inside the cell, you don't have a concentration gradient to go down anymore. So glucose doesn't go in. It's just like if you have a suitcase. You know, you're putting your clothes in, you put your clothes in, no problem, no problem, no problem. Now it's full. Now you can't put clothes in. Well, why can't you put clothes in? What's the luggage resistance, right? Why is there resistance to this luggage from taking those 2 extra t-shirts? Well, it's full. That's the whole problem. So the solution is not to give more insulin to shove glucose from the blood into this bloated cell.
Oh my God, it
You are
sounds
going to
almost
make it
barbaric when
worse.
you say that. You're literally like, why are we doing this?
Well,
That's
how
what
does
I'm
it make
thinking
sense at
now.
all? Like this
It
entire
doesn't.
underfill hypothesis, this internal starvation hypothesis of type 2 diabetes, it completely doesn't jive with what you see clinically in any way. But that's what we're taught. Instead, if you think of it as an overflow problem, well, what's the solution? Well, get rid of
Empty
all
the
that
glucose by
glucose.
getting into ketosis.
Ketosis, intermittent fasting, losing weight, you can do it anyway. You can do it low-fat diets if you want. But the point is that if you let your body burn off all that glucose, that is, you lose weight, what happens? Your diabetes goes away. You're emptying that cell just like you empty the luggage and things get better. So the point is that giving insulin is the exact wrong thing to do because you're simply making the blood sugars better, but you're making the diabetes worse, right? Just like if you have
Yeah.
all this clothes lying around, and you shove it into the suitcase is full, you keep shoving it, you keep shoving it, you keep shoving it. Well, it's better because you have less clothes to put in, but the problem, which is that that suitcase is overfilled, is made
No,
worse,
100%.
which is exactly what you see. So after years, so remember the all those studies of looking at tight A1Cs, right? Give lots of insulin, get your A1C down to 6. Did it
They busted.
cause any benefits? No,
No.
absolutely not, because you didn't actually make the diabetes better. You made the blood glucose better, right? That's the symptom.
Oh my gosh.
So the whole point is that if you think about it wrong, you get it wrong. So the whole issue is that you don't need more insulin. You actually need less insulin. Therefore, if you look at how you reverse type 2 diabetes, you don't need to give more insulin. You need to lower insulin because insulin levels are high. You need to lower insulin
Right.
levels. The primary problem is not insulin resistance. The primary problem is hyperinsulinemia. And if you think about it that way, that completely jives with what you see clinically. So to get back to cancer, so the insulin resistance, the obesity, the type 2 diabetes, they're all problems not of insulin resistance per se, but of hyperinsulinemia. So to get back to the problem of how that impacts on cancer growth is very interesting because, so you have to understand that the way that the body works is that we have certain nutrient sensors. So understand that insulin is not originally, if you look back in the evolutionary past, in primitive cells, insulin is not used for blood glucose control. Insulin is a growth factor. As we evolved, what we did is you need to tightly link growth and nutrition. That is, if you have no food coming in, your body shouldn't be growing. So you look at children who are malnourished, for example. They're very small. Then you get well nourished and they grow like they just spurt up, right? Because your body uses the same molecule for growth as it does as a nutrient sensor. When you eat, insulin goes up. You tell your body, hey, nutrients coming in. That insulin is the exact same molecule that tells your body, hey, you need to grow because you need to grow while there's food available. And that's why insulin and insulin-like growth factor are the same thing, right? They're both linked to insulin, and they're not just nutrition. They're not just hormones of nutrition, but they're hormones of growth. So you have a situation where if you were to get insulin levels to 0, for example, and this Walter Longo showed this in the, they're called the Laron dwarves of Ecuador. I don't know if you've heard of them. Fascinating sort of story. So there's this rare, group of people in Ecuador who are basically dwarves because they have IGF-1, so insulin-like growth factor, but they can't respond to it, so the receptors don't work. So essentially, they're essentially very, very low insulin levels, and they're dwarves because they don't have that growth factor. The interesting part is that they're virtually immune to cancer. They don't get cancer because the growth hormone that they need is 0. So, again, you have to understand that cancer is a disease of growth, right? And I'll get into this in a second, which is sort of how to look at cancer, which is a second really sort of fascinating problem. So cancer is really like you have to think of it as a new invasive species, basically. The cancer cell has derived from your own cell, but it's become autonomous, right? So if you have breast cancer, that breast cancer is derived from your own normal breast tissue, same as the colorectal cancer. It's derived from a normal colon cell, but has become essentially autonomous, but still responds to growth factors. So if you are worried about cells growing, well, you need to lower growth signaling, which includes insulin. Insulin is a growth factor. So you look at breast cancer, which is one of the most well-studied for insulin. Breast cancer cells have like 6 times the number of insulin receptors that breast cells do. So you'd say, why does the breast cancer cell need so many insulin receptors? Well, it runs on glucose. So you need lots of insulin receptors so you can be very sensitive to insulin, so that as soon as you get a little insulin, it opens everything up, lets glucose flood into the cancer cells. In fact, if you grow cancer cells, and this was noted sort of 30, 40 years ago, if you grow breast cancer cells and don't put insulin in, they basically die. They can't get the nutrients that they need. They can't get the glucose into that cell. Those cancer cells are highly dependent on insulin to get the glucose that they need. And this gets back to sort of how cancer energy metabolism is actually much different than normal metabolism, which is probably what Tom was talking about, and how some of that can play a role in treatment. So again, that's why breast cancer, for example, in a disease, breast cancer cells, that is very sensitive to insulin, right? Because you have so many insulin receptors on that breast cancer cell. If you have hyperinsulinemia, you're just going to be feeding that growth, right? You're just going to be feeding that growth of the breast cancer cells more than you're feeding the growth of the normal cell. So therefore, you're going to favor growth in that situation, and therefore diseases of hyperinsulinemia, that is obesity, type 2 diabetes, are well known to be associated with breast cancer. So again, if you think about it mechanistically, well, what's the solution? If you want to lower your risk, you want to try and keep your insulin levels low.
We pardon this interruption real quick. If you're enjoying this podcast or find it valuable for what we discuss and the education and how people see and think about cancer in general, we would very much appreciate a like, subscribe, and especially a share so we can bring that information as maximally and broadly as possible. Thank you so much for listening. One thing that I always used to say was, well, why is cancer, a problem of the elderly? Like, what's your biggest risk factor by far is age? And I would mostly say it's because of mutational error that goes undetected over time, gets carried over, etc. But this is a whole nother component, like that argues, well, we know that women, when you're over 65 or 70, it's like 1 in 4 chance that you'll have like breast cancer over the next coming years. That's over 70 versus over 35. Is part of that reason, like, because of the amount of growth factor and insulin that you are exposed to over time, which then permits, especially hormone positive breast cancer, like that is generally older patients as opposed to triple negative. Is it that fact that they're constantly having more insulin around, constantly more growth factor, constantly more invitations over their lifetime to just kind of get neoplastic and go rogue? That fits. I mean, that's you can see how that gets kind of super.
And you see the same thing with mTOR, for example, with, you get lots of growth in those cells. You see it if you look at rates of cancer from, we know, for example, if you have indigenous people, Africans, for example, there's a very famous, study, but it was, what was his name? He was Dennis Burkitt. He is a missionary in Africa. What was very interesting is that when they went to Africa, they found that a lot of the whites were getting colorectal cancer, same as they did in Britain or Ireland, I think he was from. But the natives did not. So the people in Africa, the Africans in Africa, didn't get colorectal cancer. When they followed this sort of white man's diet, for example, they all got colorectal cancer. And then what was the difference? He said it was fiber. Turns out fiber doesn't have much to do with it, but a lot could be due to the sort of refined diet and the sugar that they were eating. So remember, of course, the Africans were eating their traditional diet, didn't get any colorectal cancer. when you take that same African, introduce a completely different diet, which is sort of at the time, of course, highly refined flour, lots of sugar, like 10, 50 times the amount of sugar that a typical African was eating, all of a sudden, cancer all over the place. You saw the same thing in Alaska, where you have traditional Inuit who ate mostly, whales and seals and all this sort of stuff, traditional stuff. No cancers other than they got nasopharyngeal cancer due to Epstein-Barr virus, right? But they didn't get breast cancer, colorectal cancer. You take those same people, introduce a diet that is high in refined grains, so white bread and sugar. All of a sudden, you get rates of cancer that are approaching the white person. So there's a very interesting period of time in the 30s and 40s where people had actually sent, so Queen's University in Ontario, they would send an expedition every year to the Arctic to see why these Inuit people were immune to cancer. They didn't get cancer. Of course, they stopped that study because they all started getting cancer because their diet changed, right? So you have to understand that it's not really about genetics. It's about the environment, which is much, much, much more important. Not to say that genetics isn't important, but it's how...
No, but we say it all the time here. Yeah, it's literally what's happening in the cellular level in your body in your lifetime, far more than what your tendency for cancer is. If you had a true genetic tendency, most everyone would die of cancer, like if it was running. So then there's modifiable, factors.
Yeah.
Obviously, 85-90% of which is somatic, is what we call it, and in your lifetime. This is so fascinating. So again, just to distill it down, I'm sorry to interrupt you. To distill it down, am I hearing you correctly that it's really when people say the sugar causes the cancer, we really need to think more so, or equally, I don't know if it's equally or more so, that it's really the insulin that's being sent to regulate the sugar, which, remember, is a growth factor that says grow, grow, which is what cancer means in Latin, unregulated cell growth. So that's what you're saying. It's more of an issue of like you're inflaming. Don't mess with the animal, otherwise, at a zoo or whatever, because it will get mad. That's what we're doing when we're letting the insulin levels get high.
Exactly. It's basically you're encouraging growth by having all of these growth factors, which are nutrient sensors, right? Nutrient sensors are growth factors. So if you increase nutrient factors, then you will increase cell growth. And of course, cancer is a disease where anything that sort of favors growth is going to increase it. But it sort of gets back to sort of what I actually think is the most fascinating, which is how cancer develops. And that was, what I sort of talked about, which is very interesting because you have to think about it as cancer developed. There's sort of three great paradigms of cancer. In terms of, you should ask the question, what is cancer? Most people, they're like, I don't know. It's like we have this very strange disease, which is clearly there's genetic mutations, but everybody has the wrong idea in that they think it's mostly about genetic mutations when it's mostly about the environment. So we went through sort of three phases of understanding of cancer, and we're on this sort of third stage, but most people still are stuck on the second stage. So the first stage of understanding was that we thought of cancer as a disease of growth, right? That's the first great paradigm of cancer. So it's basically a cell that grows too much. So that's really good. So because that's the paradigm, you say, what's the treatment then? So the treatments are, if you have cells that grow, let's kill them. Right? So now you have surgery, which is you can cut them out. You have radiation, you can burn them out, or you can give chemotherapy, which is you can poison them, right? And those are very successful. So those were developed sort of through the 30s, 40s, 50s. You had surgery's been around a long time, but radiation was developed in the early 1900s, and then chemotherapy sort of after World War II. And then in the 50s and 60s, you started messing around with how to sort of do combinations of chemotherapy. And that was very successful, but only up to a certain point. You sort of reach the limits of that paradigm. That is, cancer is a cell that grows. How do you kill cells faster than regular cells? Well, that's one way. But you reach the limits of what that could really do. So then through the 70s, he started to change from a growth paradigm. So this is a cell that grows. So now you sort of get to the next understanding of why are these cells growing, right? And that gets you to the genetic paradigm, which is the sort of next big sort of paradigm, sort of 2.0, the big next evolution of how we think about cancer. So we think about cancer as, why are they growing? Well, they're growing because the genes are mutated, right? So you have oncogenes and you have tumor suppressing genes. And if you mutate those oncogenes, you get excessive growth. So therefore, you get into the next great paradigm, which is that this is the genetic paradigm. Now you start to develop treatments like imatinib and trastuzumab, Herceptin, for example, where all of a sudden you're not trying to kill cells anymore, right? It's a totally different paradigm, because when you give a drug such as Gleevec, it was revolutionary, right? Totally revolutionized the treatment of CML, right? So the whole point is that you're not giving a treatment that is directed at killing cells. You're giving a treatment that's directed at correcting the underlying genetic mutation. So
and inhibiting its like mechanism of growth, basically.
Exactly.
Like,
same with the HER2 new is great, like fantastic, right? So this is the 90s. So you've got oncogenes, you've discovered oncogenes, you've discovered tumor suppressor genes. So you went from paradigm 1.0, which is sort of, this is a disease of cells that grow. Now, why are they growing? Hey, genes are mutated. So let's fix that, right? We're getting to the root cause, right? So that's great. So then there's the Human Genome Project, and everybody's like, you know what? We're going to cure cancer. Because all we need to do is figure out, in this patient with colorectal cancer, what are their genetic mutations and how am I going to fix it, right? Then we're going to cure cancer. We just need to know what these genes are. So the Human Genome Project finishes in 2000. And of course, cancer is not cured, not in the least. And the problem was, and this became obvious very soon, is that it wasn't that you didn't find mutations, right? Everybody had been thinking that it was the so-called, we started with one mutation and one cancer. That was like the CML. Then you had this multi-hit hypothesis, right? You needed 2 mutations, right? So in colorectal cancer, you had 1 mutation, then you had a second mutation. And how did these mutations come? Well, they're totally random, right? It just happened that you got a mutation in this critical oncogene. So this was the so-called somatic mutation theory. And it predicted, well, you get 2 critical things hit this oncogene, you get cancer. But turns out that it wasn't that you didn't find any mutations. You found way too many mutations. So you look at a typical patient with colorectal cancer. He or she has 70 mutations. Mm-hmm. So now it becomes impossible to treat, because you cannot simply you can't treat somebody with 70 different things. The problem is, if you have patient A has 70 mutations, patient B sitting next to them in the chemo suite there has 70 completely different mutations, and yet this colorectal cancer looks exactly the same. Exactly. Pathologically, it looks the same. So it was this whole idea that it's just random genetic mutations was all wrong. Because think about it this way. If you have colorectal cancer in a Japanese woman in the 1920s, that cancer looks exactly the same as a black woman in the United States. So 100 years later, half a world away, completely different nationality, and completely different genetic mutations, yet these 2 cancers look exactly the same. And
histopathologically, like on a slide.
On a slide, yeah. And so all these different mutations, different environments, yet they look the same. How can it be random? How can you have 70 random mutations in a woman 100 years ago of a different nationality, half a world away, and it still looks the same as that cancer that's sitting in front of me? It wasn't random at all. So this somatic mutation theory that says these are just random mutations is not right, because they're not random at all. Basically, those cancers are developing according to a plan. They have to. Otherwise, how can patient A, right? It developed completely independently from their genome, that from the colorectal cancer cell. Patient B, completely independent evolution. So this whole genetic mutation theory, which is that 1, it's a couple of mutations is wrong. There's hundreds of mutations usually. So at the last, so after they did, after they did the Human Genome Project, they did the cancer genome, cancer genome study, where they took, I think, 50,000, something like that, cancers, and basically
targeted
yeah,
the mutations.
they looked at the mutations and how many mutations are there. Well, in 2018, I think I last looked, there was 6 million mutations.
Yeah.
So you're trying to develop treatments to fix these genetic problems, but there's 6 million different problems. That's not going to work. So after imatinib, after the HER2/neu, basically you could really count on one hand how many genetically targeted mutations that are really truly successful in the way that Gleevec was. It's almost none, because you haven't answered the question. Like this whole somatic mutation theory, that it's a few mutations, that's wrong. This idea that it's random, right? Because remember, if you're a smoker, you're going to get lung cancer, or you're at higher risk of lung cancer. Those are not targeted mutations, right? In the way that you can do it's CRISPR. It's basically random. The way it affects your genome is basically completely random. The way it affects your DNA is random. It's not like it targets growth specifically. So why do all those lung cancers pathologically look the same? And this whole so by the 2010s, the whole somatic mutation theory was going down basically in flames, because it wasn't developing the treatments that were actually making a difference.